Hello and welcome everyone. My name is Dr. Medhavi Gupta. Today we'll be talking about breast cancer with brain metastasis. Having metastasis in the brain can be a matter of huge concern both for the patients as well as the medical team. After lung cancer, breast cancer is the most common cancer associated with brain mets. To discuss this topic, today I'm joined by Dr. Nancy Lin. Dr. Lin is an associate chief for the Division of Breast Oncology at Dana-Farber Cancer Institute. She's also a director for the program for patients with breast cancer brain metastasis. She has an extensive research experience on this topic and has authored a number of publications, including the recent study of tucatinib in patients with HER2-positive breast cancer. In addition, she is also an author of the up-to-date section on brain metastases in breast cancer. So one of the biggest challenges in treating patients with brain metastases is not every drug crosses the blood-brain barrier to be active in brain.
Yes.
Having said that, nowadays we have few drugs that can cross the blood-brain barrier and are active in brain, especially in the HER2-positive breast cancer. Could you please tell us a little bit about these drugs? And in addition, could you also tell us, are there any circumstances in which you would consider giving these systemic treatment options first rather than sending the patients for surgery or radiation therapy?
Sure. So in terms of active agents in the CNS, I would distinguish the need for blood-brain barrier penetration across an intact blood-brain barrier in terms of prevention versus treatment. So it's probably true that to really adequately prevent brain metastases, you need good blood-brain barrier penetration. And we've seen that in the lung cancer literature with the ALK inhibitors. But it's also true that many agents that actually don't cross an intact blood-brain barrier do work in patients who have established brain metastases, presumably because the blood-brain barrier is disrupted. And obviously you can see that because you see gadolinium uptake in those lesions. But for HER2-positive disease, we fortunately have a lot of agents that actually have demonstrated activity. The one that, of course, has made the most impact in the recent past is tucatinib, based on results of the HER2CLIMB trial. And that trial randomized patients to trastuzumab capecitabine with or without tucatinib, and showed not only a progression-free survival benefit in the brain metastasis subset, but also an overall survival benefit. And in addition, the patients actually in that study were allowed to have either stable treated brain mets, which are the usual inclusion, but a very substantial proportion of patients entering that study had active or progressive brain mets. And so the treatment that was given on the study, the systemic treatment, was actually the intention was to treat the patient's CNS disease. And in those patients, again, there was a PFS, a CNS PFS, and a survival benefit, so all sort of favoring the tucatinib. But there are other agents that are active. So neratinib and capecitabine is an active regimen in the CNS, about a 50% response rate in the CNS. TDM1, in fact, has activity in the CNS. Objective responses have been reported. Lapatinib, capecitabine, one of the older regimens, has activity in the CNS. So there's certainly a number of options for CNS activity. The question about when to use systemic therapy versus local therapy is complicated, and obviously everything depends a little on the situation. And there are not any randomized trials, nor do I think there ever will be, because it's just so complicated. These are sort of case-by-case things. But the situation that I might think of is, there may be a person who has multiple very small brain metastases. Maybe they're on their second-line regimen for HER2-positive disease. So you would expect a reasonable life expectancy. And you might want to push out whole brain radiation just a little bit further, because the longer a patient survives after whole brain, the more they're likely to have these long-term neurocognitive outcomes. That patient doesn't have symptoms, and has not, for example, had tucatinib. Could be a person that you might treat with close follow-up. I think you have to counsel the patient that radiation is standard of care. That's what I do. But that's a person that, I think would be reasonable to counsel and then to follow carefully. And, because I think for that situation, trying to defer whole brain radiation does have some potential benefit. On the other hand, a patient who's on THP first-line therapy and presents with two isolated CNS brain mets, and their systemic disease is very well controlled, and they have, like, let's say 2 1-centimeter lesions, That person I generally would just refer to radiation oncology for SRS. It's so straightforward. It's very safe. People tolerate it generally very well. And then I'm just able to continue their HP. So I think those are some extremes of situations where, I might pick radiation versus systemic therapy. And certainly for the person who's very symptomatic, radiation, I think, has the advantage of being quite reliable, and the response rates are exceedingly high. So I think for a very symptomatic person who's not otherwise had previous radiation, I would recommend radiation first.
So just to add to that, once patients have treatment with either radiation therapy or surgical management, do you usually prefer to change the systemic therapy or continue the same line of treatment? I know you already spoke about HER2-positive disease. What about the other
Yeah.
subtypes?
So I think, again, it really depends. It depends on the extracranial disease status. Obviously, if the extracranial disease has progressed, no matter what subtype of breast cancer, I'm going to switch their therapy. And there, I'm going to switch the therapy to what should be an effective regimen for their extracranial disease, and then prioritize amongst those regimens that have some reported CNS activity. So if a patient has been sort of definitively treated locally, so let's suppose they have 2 lesions, they're treated with SRS in a definitive fashion. Generally, I'll leave the patient's systemic therapy alone. I think the exception is, the patient who has, sort of these multiple episodes of CNS progression over a relatively short period of time, and it's very unsatisfying to sort of just keep sending the patient to radiation oncology for SRS. And that may be a person where I, in fact, will want to switch their systemic therapy in hopes not only of treating the visible disease, but perhaps prolonging the time to the next CNS progression. There's not great data for that, with the exception of tucatinib, where we do have randomized data to support that. But I think that's certainly reasonable. Somebody who's on endocrine therapy, the risk-benefit profile of switching to another line of endocrine therapy is pretty favorable, and I would do that.